Thank you for this wonderful opportunity to present to you autologous stem cell transplant in light chain amyloidosis. What, why, when, and for whom. So today we're going to review the rationale for using high-dose therapy and autologous stem cell transplant to treat AL amyloidosis, and also discuss how the treatment landscape has changed based on recent advances. So I just want to start by saying the goal of treatment in AL amyloidosis is to target the disease plasma cell clone. And if we can target the disease clone or the pathologic plasma cell in the blood, we can see reduction of the circulating free light chains. And then over time, organs can improve, and we measure that by biomarkers such as NT-proBNP or proteinuria, or alkaline phosphatase in the setting of cardiac, kidney, or liver involvement, respectively. And then patients, it's important to have both a hematologic and organ response because that is the best chance for extended survival. And the best chance of an organ response is the deepest hematologic response, again, and that translates into a longer survival. So historically, the only available treatment was oral melphalan and prednisone, and it was a mainstay of treatment based on the initial response rate. It was the only thing that led to an initial response rate of 25% and resulted in a overall survival of about 1 year. However, cardiac patients did far worse and had a much shorter survival. However, the advent of high-dose melphalan and autologous stem cell transplant, which I'll explain, really changed the playing field and was first studied in patients with multiple myeloma. So you see here a patient who then has their stem cells collected and frozen. And that allows us to treat the patient with high-dose chemotherapy and or radiation. And then we can reinfuse the stem cells to rescue their bone marrow. So it's really a misnomer to say autologous stem cell transplant. We're really relying on the high-dose chemotherapy. So a stem cell transplant is really synonymous with using high-dose chemotherapy to treat the disease and then using stem cells to rescue the bone marrow to help repopulate normal, healthy blood cells after we deliver high-dose chemotherapy. And really, in 1994, a multidisciplinary group from BU was the first folks who studied this approach in AL amyloidosis. In the first study, there were 5 patients, and it was the first time patients achieved a complete hematologic response. Again, there was only a 25% response rate with oral melphalan and prednisone, and that was not, that was only a partial response, never got a complete response. And all of these 5 patients, after achieving deeper hematologic responses, improved their organ function, and all were alive at 12 months. And in fact, patient number 1 is actually alive and well 30 years following high-dose melphalan and stem cell transplant. So if you can get a complete hematologic response with this therapy, patients can do really, really well. This experience was then extended to over 300 patients, and now it was shown that overall survival can improve almost up to 5 years, and especially in patients who can achieve, again, the complete hematologic response. Still, we saw that patients could live for many years, but the patients with cardiac disease still did far worse, even when they're treated with high-dose melphalan and stem cell transplant. And it's this early drop-off of patients who died early despite getting therapy, probably because they had advanced cardiac disease and either died of their disease or died of toxicity from transplant. Other risk factors for not doing well with stem cell transplant include renal impairment and advanced age. And that led us to do a series of trials where patients eligible for stem cell transplant were risk stratified based on their age, kidney disease, and cardiac function. And based on these factors, patients had dose modified melphalan after transplant. And this was to try to reduce the toxicity associated with transplant. And once we restaged them after 3 months, those who had a complete hematologic response were observed because, again, those patients do very well. And those who had less than a complete response were offered a series of consolidations after transplant to try to improve their hematologic response. And really, with what we call risk-adapted stem cell transplant, meaning risk-adapted melphalan dosing plus stem cell transplant, in 2017, we reported in 143 patients where the median survival was beyond 10 years, which was really incredible results for a treatment for patients with AL amyloidosis. And we saw that patients who got complete hematologic response, the complete hematologic response rate improved from about 25 to 30% after transplant to about 50 to 60% with consolidation if we used novel drugs after transplant. There still was an early drop-off. 8 patients died within 100 days for transplant-related mortality of 5%. Again, patients with multiple myeloma are more easily treated with this paradigm, and transplant-related mortality is less than 1% in that population. But we started hand-selecting patients better after we realized that 7 out of 8 patients with advanced heart disease died. And again, this early drop-off is probably not just necessarily related to the therapy, but really their advanced heart disease, because there were really no deaths in patients who were treated with MEL 200, meaning the patients who were eligible to get the highest dose because they didn't have advanced organ disease did fine, but those who got lower doses because they had more advanced disease were at higher risk of death from in this setting. And it's really not the melphalan that kills them, it's the advanced organ disease. But refining the patient selection, risk adapting the melphalan dosing, and with post-transplant consolidation, this is really became our standard of care. And the Boston group recently updated a 40-year natural history study of all their patients, over 2,000 patients who were treated between 1980 and 2019. And you can see that patients who were treated with stem cell transplant had a median overall survival of 7.5 years versus 2.9 years for those who were non-transplant candidates. Over the decades, they showed this data by era 1, 2, 3, and 4, their 40-year natural history study. And you can see the 5-year overall survival increased in patients who received stem cell transplant from 54% to 76% in the most recent era, and early mortality decreased similarly. And you can see there were similar increases, or at least some increase in overall survival in the non-transplant patient, but not as great. The early mortality also decreased significantly. But you have to understand that we moved some of the patients who were transplant candidates into the non-transplant candidates. So we kind of moved by refining patient selection. We escalated the outcomes of patients who were transplant candidates and a little bit decreased the outcomes of patients who were non-transplant candidates. Similarly, the Mayo group showed they really looked at who were the 10-year survivors and looked at a period of 2000 to period of patients who were diagnosed between 2000 and 2008, so they can follow them for at least 10 years. And they saw that 22% of patients diagnosed between that time did survive 10 years. And there was a significant increase in the patients who had received, there were a significantly increased proportion of patients who had received transplant in that group. And amongst the patients who received stem cell transplant, 50% of them survived greater than 10 years. So really, all of this data really suggests that the surest path to long-term survival as an AL amyloid patient is to both qualify for, because this has to do with patient selection, and receive high-dose therapy and autologous stem cell transplant, up until the recent era. But only 25% of newly diagnosed patients are actually eligible for stem cell transplant. So what do we do about that? And more recently, the Andromeda study has been reported where patients were treated, newly diagnosed patients were treated with a combination of VCD or Velcade Cytoxan and dexamethasone with or without the immunotherapy daratumumab. And in almost 400 patients who were randomized to receive 6 cycles with or without daratumumab, and then maintenance with daratumumab in the patients who were randomized to the daratumumab arm, the hematologic response rate increased by 3 times in the patients who got the immunotherapy with the combination chemotherapy, and organ responses doubled. And so Dara-VCD is the first and only FDA-approved drug regimen for this condition. And it's important because this has really become the standard of care for almost all newly diagnosed patients with AL amyloidosis. And with longer follow-up, the hematologic response rate, complete response rate, in the Dara-VCD arm is 59%, and that is really similar to the best results we've seen with stem cell transplant and consolidation. So the question of stem cell transplant in the year 2024 is really being questioned now, and there's 2 kind of schools of thought. That Dara-VCD increases the CR rate and now and improve organs, and now instead of 25% of patients being stem cell transplant candidates, maybe we'll have more stem cell transplant candidates. And that really goes with, we have all this long-term data showing the benefits of stem cell transplant, and we don't have any long-term data with Dara-VCD. However, there's another school of thought that now that Dara-VCD increases the CR rate and improves organs, maybe we don't need stem cell transplant, and we can limit stem cell transplant to patients who have not achieved the deepest responses. And really, to answer that question, we're doing a randomized control trial studying Dara-VCD as upfront therapy, and then randomizing patients to continuing Dara-VCD or receiving transplant. And it's these kinds of clinical trials that are necessary in order to answer this question. So hematologic response predicts but does not guarantee organ response, and organ responses evolves over time. And I'm just giving one example so that to make this point, this is some data from a patient of mine who received a stem cell transplant as their upfront therapy in 2008. And this is their serum-free lambda light chain, which is the marker of their disease. So after stem cell transplant, you can see here there was a decrease, but not a normalization of her serum-free light chain. So she actually didn't have make criteria for a hematologic response, and then received Velcade as consolidation afterwards, and only got 1.5 cycles because developed neuropathy. And then she got a complete hematologic response, and 16 years later remains in a complete hematologic response without any additional therapy. Sure. She had kidney as her organ involvement with very significant protein loss in her urine, at a peak of over 20 grams in 2008. And although she achieved a very prompt hematologic response in 2008, it wasn't really until 2014 till her urine protein excretion was below 1 gram, and now since 2018 is undetectable. And that goes along with the albumin in her blood, because she's losing protein in her urine, the albumin in her serum is low. And although, again, she achieved a hematologic response in 2008, her serum albumin level didn't normalize until 4 years later. So this just goes to show you that the median time to best renal and cardiac responses are long, even if you can get a prompt hematologic remission, and you have to be patient. So the standard of care for AL amyloidosis incorporates the monoclonal antibody daratumumab and has really changed the treatment paradigm. This may ultimately increase or decrease the use of the stem cell transplant in the upfront setting, and that is currently being studied. Organ responses take time, and so when patients achieve a hematologic response, often there's still organ disease there, and physicians in the community don't know if they should continue to treat the hematologic disease, but it is not an indication to continue or change therapy. If the patient has achieved an optimal hematologic response, we just have to be patient. Nothing replaces the importance of early diagnosis, because if we don't diagnose this disease early, patients can have advanced organ disease, and even, again, with appropriate and good hematologic responses, it does not guarantee that the organs will improve. And really, participation in clinical trials is absolutely essential, because, again, we only have a single drug regimen FDA approved for this condition. With that, I want to thank you for your attention.